This was actually designed by a woman named Sharon Inouye, who also designed a program called the HELP, or Hospitalized Elder Life Program. And it's a way to, we're actually starting to roll it out at CPMC. It's a way to identify people who have those risk factors for dementia and how to put in place methods to prevent it. So this is, and actually it was funny when we were talking about the questions for the competency, we're talking about treating delirium. You can't, I hate that this is on videotape because this will one day be completely, hopefully, proven wrong.
It's just for this year.
So I don't think in a year they're going to find a treatment or cure for delirium. There's no way to treat delirium. The only way to treat delirium is to prevent it from happening in the first place. So when your patients are already here, they're coming in, they're already delirious, then you definitely have things that you can do to sort of prevent the worsening of the situation and give them a good healing environment. But ways that you can help prevent it in your patients who aren't delirious is repeated orientation. When you go in and you ask a patient, and I see people do this a lot, and it's a mistake that I used to make. You ask a patient, what's the date? And they say, oh, it's June 7th, 1952. You don't just go, 1952, and walk out the door. You say, no, actually it's 2010. Not in a controversial way, but just reorient them. Very close, but it's actually June 7th, 2010. You know, and that way the patient eventually will hopefully get it. Early mobilization, we talked about this. Keeping patients in bed hastens the homeostenotic process, hastens bone loss, hastens muscle loss. So get them up, get them out of bed, and it's not a hot potato. It is everybody's job. The physician should be getting patients out of bed, the nurses should be, the therapist should be, dietary should help. At least say, this patient needs to get out of bed rather than dropping off trays. Everyone's job. Sensory aids, hearing aids, glasses. You know, promise the families we'll do our best. Teeth. I didn't mention this, but I'm actually medical director at our Alzheimer's unit, Swindells, which is at one of our other campuses, and we just cute little story. We have this patient who the family said, we really don't want to leave her dentures here because they're very expensive, and how's she going to eat? Well, turns out she likes to take her dentures out and throw them in the trash can. So every day the poor staff was having to dig through the trash cans. And then we kind of got it that she actually doesn't use her dentures that much anyway because they're always in the trash can. But for the most part, you should ask for sensory aids. Avoiding dehydration. Don't keep your patients NPO for tests that are not going to happen. Avoid all restraints. Okay, this is a little controversial for y'all because I know that you have some people where you can't avoid it. But consider what a restraint is. We think of restraints as just being maybe wrist restraints or posy or sometimes 4-point, but Foley catheters are a restraint. I don't know if anyone's ever had a Foley catheter. You have to carry that bag around. Foley catheter is a restraint. An IV is a restraint. I don't know how to disconnect those things, and I'm not an unintelligent person. So you can imagine somebody who's sitting in bed, they don't know how to take that off so they can go to the bathroom. The beds, the tables that you put in front of patients that kind of lock them into bed, those are hard to move. Those are restraints. Beds can be restraints, the way they fold you up like a taco, when you're in bed. So those can be restraints. Remember what a restraint is and try to avoid them. Also, something that I get a lot about restraints is people will frequently argue to me, well, I'm afraid the patient might fall. If they're in an appropriate environment, I understand that sitters are expensive, but if they have a family member or somebody who's nearby and they can contract for safety with, then it's better to use that. When people who have been restrained do fall, their fractures are usually worse. And again, this has to do with losing more bone and losing more muscle because they're restrained. Review medications daily, if not more than once a day. There are so many cooks in the kitchen when you come into the hospital. Doctors on this shift, nurses on this shift, everyone's changing medicine, PRNs are given and not documented. Review medications. Using non-pharmacologic strategies for sleep. So there actually was a study, I think it came out of UCLA, which is where I did my fellowship, and they put, I can't remember what the sleeping medication was, but a sleeping medication up against warm milk and a back rub. And the warm milk and a back rub actually worked better for patients in terms of actually getting them to sleep and getting a restful night's sleep. I am not recommending you give your patients unsolicited back rubs, okay? But I'm just trying to prove a point here. Cognitively stimulating activities. TV is not cognitively stimulating. Conversation is cognitively stimulating. Reading the newspaper is cognitively stimulating. Magazines, novels, listening to music, listening to classical music. Actually, there's a lot of data on that. So treating delirium, like we said, no real way to treat delirium. You can only prevent it. Please, in order to treat delirium, please don't use benzodiazepines, okay? If you have someone who's agitated, don't use benzos unless they are withdrawing from alcohol or special consideration in patients who have Parkinson's. So sometimes they will respond to benzos. But benzos, for the most part, are deliriogenic. They're not helpful. Okay, pain medications. Don't use pain medicines to treat delirium unless, that's what the asterisk is there for, unless the patient is in pain. Obviously, you treat them with the pain medicines. Always remember there are non-narcotic alternatives. Do not use muscle relaxants. I think the time that I wrote this slide, I actually had gotten a request to give a patient baclofen for delirium, and I wasn't really clear why. The patient didn't have muscle spasms or wasn't in pain, so that's kind of why I put that on the slide. It was sort of at the moment. Okay, do not use anticholinergics. The one that's most popular is Benadryl, and people use Benadryl personally, and actually one of my partners swears by Benadryl for sleep. So these are going to be people who write prescriptions for sleep for patients. Benadryl is not a sleep aid, and it's very deliriogenic. There is some thought that the actual physiologic cause of delirium, and we didn't really review this, has to do with cholinergic transmission. So if you think about it, when you have somebody who has dementia who is at high risk for delirium, these patients can be treated with medicines that sort of increase the cholinergic transmission. So we're talking about like Aricept and Namenda. So you imagine if you disrupt that transmission, then you're going to end up more cognitively impaired or delirious. So when you give patients anticholinergics, this is one of the side effects, is delirium. So don't give Benadryl. There are indications for Benadryl, but it is deliriogenic.
Are there recommended medications for pain then, or for sleep? Some really can't sleep, so the Namenda was.
So for sleep, actually the one that I've sort of was always taught, although I haven't really seen good studies on it, but I was sort of taught was the least harmful was trazodone for older patients, that it tends to be the least deliriogenic. Of course, you want to look at their other medications, and some people will only give trazodone if the patient actually has depression along with it, which if somebody's really having trouble sleeping, not just because they're in the hospital, they're really having trouble sleeping, then they might have some underlying emotional disturbance. And then you asked, I'm sorry, what was the other? Pain, yes. So I would recommend sort of starting off with non-narcotics. It depends if the patient's already on as an outpatient, because you can have some opioid withdrawal. So if they're already on opioids, you would want to sort of start backing off of them very slowly and then introducing the anti-inflammatories at the same time. And Tylenol is the one that I tend to recommend first because so many older patients do have renal dysfunction, but you can definitely introduce NSAIDs at lower doses, definitely. Also, you want to consider with NSAIDs sort of GI disruption, and can be upsetting to their tummies, and then you end up giving them something else for their tummy, and then they're on too many medicines.
What do you think she would take, or what would he take, or what do you think would work, kind of thing, or since they don't know the patient, I know.
Right, well, and so, yeah, everybody is a little different. I mean, Tylenol is usually sort of first line. Always remember, though, if you do have patients who are on opioids and they're on Vicodin or Percocet, or Norco, something that has acetaminophen on them, remember that it has acetaminophen in it. So we are a liver, CPMC, the Pacific campus is a liver transplant center. So we have seen a lot of what we call therapeutic misadventures, and these are people who were told, you know, try to stay away from narcotics if you can, so they'll take a Vicodin every now and then they're supplementing with Tylenol, and then they come in with the Tylenol overdose because nobody told them that acetaminophen is Tylenol, and that's what's in the Vicodin. But yeah, good question.